This is Chapter 25 out of your Lewis textbook, Nursing Management of the Patient with a Burn. So a burn occurs when there's any injury to the tissue that's caused by heat, chemicals, electric current, or radiation. There's different types of burn injuries. It could be a thermal burn, a chemical burn, smoke inhalation injury, an electrical burn, or a cold thermal burn. So thermal burns, this is caused by a flame, a flash, scalding, or any contact with a hot object. It's the most common type of burn. It's just a picture of a full thickness thermal burn and a partial thickness thermal burn. And another partial thickness thermal burn. A chemical burn. This is from any like acidic chemicals. It could be from like household cleaners, battery acid. And these are really hard to manage because the damage continues on for up to 72 hours after the initial injury. Injuries can be to the skin, the eyes, the respiratory system. It can cause damage to the liver, kidneys. Your priority is to remove the chemical as quickly as you can from the skin. Try to contain or remove the clothing that the chemical has come in contact with. Smoke inhalation injuries. This results from inhalation of, it could be really hot air or chemicals. It causes damage to the respiratory tract, and this really is an emergency because this can cause mortality quickly. There's three types of smoke inhalation injuries. This is carbon monoxide poisoning, inhalation injury above the glottis and then below the glottis. So carbon monoxide poisoning, it can cause hypoxia and death. If you ever find a patient a patient comes in unconscious after being in a fire, make sure that you're assessing for carbon monoxide poisoning. It's treated with 100% humidified oxygen. The patient may have what we call a cherry red tongue, or their skin might be kind of cherry red in appearance. And carbon monoxide poisoning can be with the absence of a burn injury, or it could be with a burn injury. Inhalation injury above the glottis. This is thermally produced from inhalation of hot air, steam, or smoke. What happens is the oropharynx and larynx becomes burnt, and so you'll have edema, which is going to cause a mechanical obstruction. This is an upper airway injury, and it's a medical emergency. So some clues that the patient may have this type of injury. They'll have singed nasal hair, singed eyebrows, the presence of facial burns. They might have some like black soot around their nose, around their mouth. They might complain of painful swallowing, have a hoarse voice. They might have their clothing around their chest and neck might be burnt. An injury below the glottis. This is different from above the glottis because the patient might not develop pulmonary edema for 12 to 24 hours after the initial burn. But you really need to make sure that you're watching for acute respiratory distress syndrome. So you're going to watch for dyspnea, you're going to watch for tachycardia. Electrical burns. This results from electrical current, so voltage. Can cause death. There's just an example of a couple of electrical burns. The severity of the injury is going to depend on the amount of voltage, how big the patient is, the pathway of the voltage, and the duration. How long was the patient electrocuted? But if the electrical current passes through vital organs, they are at higher risk for death. Electrical sparks may ignite a fire, and so then the patient could result in an injury from thermal and electrical injury. And the severity of the injury can be difficult to assess because the damage will occur beneath the skin. This is what we call the iceberg effect. And these patients are at risk for dysrhythmias, metabolic acidosis, and they'll have a release of myoglobin, and that will lead to acute tubular necrosis. Cold thermal injury, this would be like a frostbite. The common places that that patients are at risk for developing frostbite is like the fingers, the toes, the nose, the ears, the face. So the severity of the injury is determined by the depth of the burn, the total body surface area that is burnt in percent, the location of the burn, and some patient risk factors. Burns are defined by degrees. There's first, second, third, and fourth. And according to the depth, there can be partial thickness or full thickness burns. Superficial partial thickness just involves the epidermis, so just that kind of the upper crust of the skin. The deep partial thickness is the dermis, and then the full thickness is like the fat, the muscle, it could be the bone. So there's two common guides, commonly used guides for determining how bad the patient is burnt from body surface area. And this is the Lunt-Browder chart, and this is considered the most accurate. And then the rule of nines. So these are based on percentages. The Lunt-Browder gives a certain percentage for every body part. And the rule of nines just kind of has it generalized. So here again, the location of the burn is related to the severity. So like the face, the neck, the chest, if these are burnt, the patient is at risk for respiratory complications. If it's like the hands, the feet, the eyes, the joints, they're going to have a problem with self-care. And then ears, nose, buttocks, and perineum, they're at higher risk for infection. Patients may develop compartment syndrome from burns. So some of those patient risk factors, I talked about patient risk factors being included in how bad patients were burnt. The older adults and infants, they'll heal more slowly than like the younger adults. A lot of older adults have pre-existing conditions like diabetes. They're going to have poor healing. Any cardiovascular, like circulatory disease like a venous stasis is going to result in a poor prognosis. The patient may be physically debilitated, and so that causes a poor outcome. If the patient is a drug abuser or an alcoholic or malnourished, fractures, head injuries, or other trauma leads to a poor prognosis. So the phases of burn management, there's pre-hospital care. This is before you get to the hospital. The emergent, the acute, and the rehabilitative or restorative. So the pre-hospital care, if you are on site, you want to make sure that the person is removed from the source of the burn and stop the burning process. But make sure that you are protected if you are doing this. You should be trained, like a trained firefighter. If the patient has an electrical injury, remove the patient from contact with the source. If they have a chemical injury, try to get off those clothes. Try to put some water on them. get any solid particles off the skin. If it's a small thermal burn, you're going to cover with a clean, cool, moist towel. And you're going to want to make sure that you don't keep it on for more than 10 minutes because you don't want the patient to have hypothermia. If it is a large burn, airway, breathing, circulation is your first priority. But then for these burns, you're not going to put them in like a damp towel. You're going to put them in a clean, dry blanket or a clean, dry towel. And this is because, when the patient has a large area that is burnt, our skin, remember, kind of thermoregulates, and so then they're at risk for hypothermia if you immerse them in cool water or put a damp cloth on them. So again, get that, remove that burned clothing and then just wrap them in a dry sheet or a towel or a blanket. You're going to watch for signs of respiratory distress. You're going to want to make sure you treat any inhalation injuries quickly. The emergent phase is the period of time required to resolve the immediate problems resulting from the injury. Usually lasts up to 72 hours. And really our primary concerns is, again, airway, breathing, circulation. So we're looking for any airway problems, hypovolemia, edema. The patient's going to have a lot of fluid loss and then edema. So that fluid is going to go to, the interstitial spaces, and like I said, the patient will have a lot of edema. So fluid and electrolyte shifts. The greatest threat is hypovolemia, and this is caused by a shift of fluids out of the blood vessels as a result of increased capillary permeability. So again, this patient has all this fluid shifting into the interstitial spaces. There's just a picture of kind of what some of that facial edema looks like. So the patient is going to have edema, they'll have a decreased blood pressure, increased pulse. They're going to have a decrease, or they're going to have an elevated hematocrit due to hemoconcentration. They'll have a shift of sodium to the interstitial spaces, and then the potassium will shift, and then first into the injured cells, and then will be released into the extracellular spaces. So inflammation and healing. Neutrophils and monocytes will kind of race to the site of injury to try to heal. Wound repair will start in the first 6 to 12 hours after injury. The WBCs, though, will be defective because of that tissue damage impairment. So the patient, they already have the skin barrier that's destroyed, their bone marrow will be depressed, they'll have decreased immune globulins, and then with this defect in the WBCs, it puts them at really high risk for infection. They might be in shock, they might have pain, again, hypovolemia, blisters. They may develop an adynamic ileus, so what's going to happen is the blood is going to rush all to their vital organs because it's the body's natural response to trauma. So the patient will have hypoactive bowel sounds. You might notice that they have some shivering because, again, the skin helps us with thermoregulation, and with the loss of skin, their body is having a hard time keeping in that heat. Your main priorities at this time is going to be airway, breathing, circulation. taking their vital signs, putting on oxygen, assessing their level of consciousness, doing a cardiorespiratory assessment. So cardiovascular, they're at risk for dysrhythmias because they have that potassium shift. They're going to have the impaired circulation. It could become kind of like a compartment syndrome, and they'll have tissue ischemia, and that can lead to necrosis. So what they'll do is an aspirotomy, where they'll just make an incision and kind of remove some of that tissue. The patient's going to have impaired microcirculation. So they're going to have an increase in viscosity. They'll have damage to the capillaries, but this can be corrected by an adequate fluid replacement. So the respiratory complications, there again with the upper respiratory tract injury, they're going to have edema that will develop, and then it will cause a mechanical obstruction. If it's lower airway, there again, they may not exhibit signs until 12 to 24 hours. They can develop pneumonia or heart failure because of the fluid replacement. They could replace the fluid way too quickly. They're at risk for VTE due to decreased circulation and immobility. Their urinary system, they're going to have decreased blood flow to the kidneys. It's going to cause renal ischemia. There again, when the muscles are damaged, they're going to have release of that myoglobin, and it's going to create almost like a jelly-like substance in the kidney tubules, and it'll cause acute tubular necrosis. So airway management, they may need to be intubated. They need to have 100% oxygen and humidified air. Make sure that you're putting a large IV bore. If they have greater than 15% of the total body surface area burned, make sure that you're putting 2 large bore IVs. And the type of fluid replacement is going to be based on the size of the burn, the person's age, their weight. The gold standard solution is LR, and they're going to use this Parkland-Baxter formula, which is it's the same thing in kids. It's 4 milliliters per kilogram, or 4 milliliters times the weight in kilograms times the total body surface area burned. So again, if the patient weighs 100 kilograms and they have 50% of their body burned, they're going to need a total of 20,000 mLs. So 10,000 of that goes over in the first 8 hours, and 10,000 goes over in the next 16 hours. The wound care should always be delayed until you stabilize the airway, ensure that the patient has adequate circulation. Cleansing can be done in a cart or in a shower or in the bed. The patient may need debriding, and this is removing the loose necrotic skin. This can also be done in the OR. This is a picture of the hydrotherapy shower. Debridement of a full thickness burn. So the shower, the water should not exceed 104 degrees. The patient will have a shower every day. Usually a dressing change a couple times a day, unless if it's a special type of dressing. Infection is the most serious threat, and it's because of the patient's own natural flora. We have our own microorganisms living on our skin, and when our skin barrier is taken away, then we're at risk for infection even by our own germs. So there's a couple different methods for wound care. There's the open method, and that's where they put like a topical antibiotic on the wound, but they won't put a dressing on to cover the wound. But the most common type is the closed method, and that's where they will put the topical antibiotic on, and then use sterile gauze to cover. There again, the dressings can be changed a couple times a day, or depending on the different dressings used. But usually the physician and like a wound care nurse will work together to formulate a plan of when the patient should have dressing changes. Make sure that you're using sterile gloves when doing dressing changes. You should be wearing a disposable hat, mask, gown, gloves, and this is to protect the patient, almost kind of like a reverse isolation. You know what, I mean, and there again, making sure that the procedure is sterile to protect the patient from infection. So skin grafts. Skin grafts can be from the patient's own skin, from a cadaver, from like an animal like pig skin, or like a biosynthetic skin. Making sure that you're doing eye care, so if the eyes are burned or the patient has periorbital edema, they'll use like an antibiotic ointment. Make sure that any hands or arms are elevated, or legs elevated on the pillows. But if they have burnt ears, make sure that you're not using pillows, because then the patient's putting pressure on those ears by lying on the pillow. Keep the perineum as clean and dry as possible. Make sure that you're getting PT involved and you're doing those range of motion exercises with the patient. Drug therapy, they'll need analgesics and sedatives. Some common ones you'll see in practice will be morphine, Dilaudid, Haldol, Ativan, Versed. And you're going to give these to the patient IV, because it's going to, the onset of them will be faster. Plus, you're going to want to try to avoid IMs, especially if, it's a burnt area, because, with all this edema, that medication's just going to sit in the tissues. You're going to want to make sure you give a tetanus booster, and that is routine to all burn patients. So some of the antimicrobial agents, so the topical, they'll use Silvadene, will be one you'll see in practice a lot. And then if the burns are pretty extensive, a lot of times they'll put them on an antibiotic to prevent sepsis. They'll do VTE prophylaxis, so like a heparin or Lovenox. Nutritional therapy. The fluid replacement takes priority over all nutritional needs, but as soon as you've corrected the fluids, the patient is going to need nutritional support for wound healing. The patient will be in a hypermetabolic state, and so they're going to have an elevated core temperature, and for an average patient, they'll need about 5,000 kcal per day. This can be adjusted a little bit. A dietitian may adjust it depending on the patient's weight. So if they're a smaller person, they may not need as many calories, or if they're larger, they'll need more. So the patient can get nutritional therapy orally, through enteral feedings. Make sure that the patient's getting plenty of protein and vitamins. So the acute phase, this is, it begins with the mobilization of the extracellular fluid and when diuresing starts. And it's concluded when the burned area is covered with skin grafts or when the wounds start to heal. So again, the patient's going to start diuresing. If they have a fluid output of at least 30 to 50 mLs per hour, it indicates that fluid replacement was successful. We talked about the absence or or diminished bowel sounds, but by this acute phase, the bowel sounds will start to return, and the WBCs, make its way to the wound, and phagocytosis will begin to occur. The necrotic tissue will begin to slough, and you'll get granulation tissue. So then the partial thickness wounds will form eschar, and then once the eschar is removed, re-epithelialization will begin. If it's a full thickness wound, it'll require some debridement. Our sodium, from excessive GI suctioning or diarrhea or water intoxication, the patient could have hyponatremia. NG feedings can cause metabolic acidosis, so be watching for that. The potassium, the patient can have hyperkalemia, so watch for cardiac dysrhythmias, EKG changes, muscle weakness. Again, with like vomiting, diarrhea, they could then develop hypokalemia. Infection. Again, I said it was one of the biggest complications to the patient. Cardiovascular and respiratory. The same complications from the emergent phase will proceed over into the acute phase, so they can have pneumonia, heart failure. Neurologic system. Sometimes they'll have some disorientation, combative behavior. They can have like hallucinations, delirium, PTSD. So make sure that you've made a referral to like counseling, and psychiatrists. They can help the physician determine what medications to put the patient on. The musculoskeletal will have decreased range of motion. They can develop contractures. The GI, they can have a paralytic ileus, have diarrhea, constipation. They're at risk for GI ulcers because the body has been through so much stress, and so you'll want to give like an H2 inhibitor or like a proton pump inhibitor. You're going to really monitor their intake. So like if the patient was taking like a Zantac, you're going to want to monitor to make sure that the patient is eating and that they're not having symptoms of GI ulcers. So they're not having the stomach pain or vomiting blood, that sort of thing. The endocrine system, you're going to want to do regular AccuChecks, even on patients who are not diabetic, because there again, our body is under so much stress. So nursing management, you're going to manage the wound care, the graft site, pain management, get PT, OT involved, nutritional therapy, psychosocial care. The wound care, you're going to observe for signs and symptoms of infection. You're going to do the assessment then, cleaning, debriding, wound measurements, and doing those dressing changes again, whatever the physician or wound care nurse orders. Enzymatic debridement. This speeds up the removal of the dead tissue from the healthy wound bed. The excision and grafting. A couple different ways they'll dress it. They may leave the grafts open. They'll use unmeshed sheet grafts for facial grafts. So excision and grafting, so they're going to remove the eschar tissue. And then the graft is placed on clean tissue. And then the wound is covered with autograft. And then the donor skin. And then the choice of dressing, again, up to the physician. So, some options of graft could be from the patient's own skin. This is called culture epithelial autografts, and it's grown from biopsies taken from the patient's own skin. And it's used in patients with a large body surface burn or those who have limited skin for harvesting. So pain management, there again we talked about the morphine, Haldol, Ativan, Versed. You can use non-pharmacological strategies like relaxation, music therapy, get PT, OT involved for range of motion. And fitting of splints, because remember they're at high risk for developing those contractures. So nutritional therapy, again making sure that the diet is high in protein, high in carbs. Try to incorporate the patient's favorite foods if you can. Make sure that daily weights are being done. Get a social worker involved. For the psychosocial aspect, remember we don't always think of those, barriers in care like financial status. Maybe this burn has completely debilitated the patient where they're never going to be able to go back to work. So you're going to need a social worker to help get resources for this patient. Get pastoral care involved based on whatever the patient's religion or spiritual preferences are. So the rehab phase begins when the burn wounds are healed and the patient can go back to a level of self-care activity. So the burn wounds are healed either by primary intention or by grafting. And this occurs in 4 to 6 weeks. But the skin never completely regains its original color. The patient, please let them know that the discoloration of the scar will fade with time, and pressure can help keep the scar flat. So to prevent hypertrophic scarring, like if the patient had burns on their legs and it's healing, put compression on. So maybe a TED or a JOPE stocking is going to help prevent that hypertrophic scarring. Make sure that you teach the patient that they may be hypersensitive to cold, heat, or touch, and that they need to stay out of the sun for at least a year. Again, the contractures, they're at risk for this, especially during the rehab phase, so make sure that you're using that splint and doing those exercises that were ordered per physical therapy. So nursing and collaborative management. So teach both the patient and the family how to care for the wounds. And then more than that, the patient may need some cosmetic surgery. Make sure that you encourage the patient to do their exercises, address spiritual and cultural needs. For our geriatric population, normal aging puts these patients at higher risk because their gait is not as steady, their eyesight and hearing is poor, and for these patients the wounds are going to take longer to heal. Make sure you're meeting the emotional needs. Getting burned is a traumatic experience. So again, they might have issues with PTSD, issues with sexuality. So make sure that you're providing that support or making referrals to the social worker, to different support groups. And then self-care for yourself. It might be difficult to cope with caring for a patient with a burn injury, so make sure you're practicing good self-care spiritually, emotionally, mentally, and physically.